Atrial fibrillation requires little in the way of introduction to paramedics. It's something we see relatively frequently, and it is in fact the most common out-of-hospital arrhythmia. And as the longevity of our population increases, so does the incidence of atrial fibrillation. Now, in Aotearoa, New Zealand, we have an overall incidence of 1.3% of atrial fibrillation across the entire population, but this dramatically increases from the 55th year of age and will go to 4.4% of that particular population. Its impact on health, and in particular a 4 to 5-fold increase in the incidence of stroke, continues to significantly impact mortality and morbidity in the older populations in our country. Maori and Pacifica are likely to be at twice the risk of developing atrial fibrillation, and it's likely they're going to be diagnosed 10 years earlier than their Pākehā counterparts. They're also more at risk of a severe CVA. Now, an epidemiological review by Cornish et al. Noted multiple causes for atrial fibrillation, but advancing age is the most prevalent of these. Now, in addition to the risks for CVA, their research reveals links between atrial fibrillation and a higher likelihood of heart failure, and also double the chance of having an acute myocardial infarction. The knock-on effects of these comorbidities are also higher. One of the ones that we're learning more about is dementia, and this is proven to be more and more prevalent in the groups that suffer from atrial fibrillation, and the risk for this multiplies if the person's had a stroke as well. Now, the National Heart Foundation of Australia and the Cardiac Society of New Zealand and Australia have recommendations for managing atrial fibrillation. Now, these include antiarrhythmic strategies. And these could either be short-term strategies to revert someone, or it may be because of the person's condition and the persistence of the atrial fibrillation that they actually need long-term pharmacological intervention or even ablation therapy to be able to revert the rhythm and avoid the atrial fibrillation. The societies recommend antiarrhythmic drugs to control atrial fibrillation, and where there is no structural heart disease, we quite often see patients on sotalol or flecainide. Now, as an aside, and of some interest to paramedics, is the fact that both of these drugs are somewhat notorious for lengthening the QT interval, and if this is not controlled or recognised, it can significantly add to the patient's risk profile. But we'll have a look at this more later in the course. The primary goal of giving drugs like sotalol and flecainide is a reversion to sinus rhythm. However, this is not always achieved, and clinicians may have to adjust the dosage or the type of the drug to include maybe a beta-adrenergic blocking drug to achieve rate control instead of reversion. Now, if this is the case, the patient's also likely to be taking anticoagulant drugs. The recommendation for anticoagulations is based on a risk scoring system. Now, we won't go into this, but obviously when the risk meets a certain threshold, someone's going to be prescribed warfarin or perhaps a non-vitamin K agent such as dabigatran. Warfarin is preferred in the presence of structural valvular diseases such as mitral stenosis, or where mechanical valves have been implanted in the heart. The dose for the warfarin is titrated against the INR, which is a blood test that predicts the risk of bleeding. The warfarin dose is adjusted to maintain the INR between a level of 2 and 3. Now, if it's too low, that is not enough warfarin on board, a low INR is going to be predictive of a thromboembolic event such as a stroke. On the other hand, if too much warfarin is given and the INR becomes too high, it becomes very predictive of a hemorrhagic event, and if the patient has a fall and hits the head, this can be disastrous. The testing schedule might vary between a week and 6 weeks. It all depends on the duration of the treatment and the long-term stability for the results. What generally happens is people take the blood test either at a 1 week, 2 week or a 6 weekly period, and they're normally rung either that day or the next day with the results and told what additions or subtractions they're going to make from their warfarin regime. On the other hand, dabigatran is recommended in the absence of valvular disease. And for those that are taking dabigatran, they don't have to undergo INR testing. Let's get back to the main focus for this session, which is the recognition of atrial fibrillation on ECG tracing. The most recognisable characteristic of atrial fibrillation is that it is an irregular rhythm, which is to say that the R to R intervals appear quite chaotic in terms of their timing. When you couple this with the absence of P waves, you have most of what you need to work out that it's atrial fibrillation. The mechanism that causes atrial fibrillation is thought to be a large number of micro-reentrant circuits that have a combined discharge rate of greater than 300 beats per minute. The location of this large number of pacemaker sites and the sequence of these discharges is entirely chaotic. The electrical signals they produce are going to swamp the sinoatrial node, denying it the opportunity to polarize, and instead of a P wave, the ECG is going to show fibrillation waves on the baseline. The rate of these sequences is going to swamp the atrioventricular node, which, having transmitted one of these signals, will then be in its refractory period, and is going to be entirely unpredictable to judge the amount of time it will take to recover and transmit a subsequent signal. The haphazardness of the AV node transmission is what makes the R to R interval so unpredictable. The second issue with atrial fibrillation is that the number and the rate of the discharge of the micro-reentrant circuit prevents any possibility of an organised depolarisation sequence, and hence there's going to be no organised contraction of the atria. In fact, the mechanical action that can be seen is pure fibrillation. This in turn has two outcomes. Firstly, there's a loss of atrial kick to complete the ventricular filling. The amount of blood entering the ventricles is going to be less, and when there are faster heart rates or in the presence of structural disease such as heart failure, this can cause cardiac output to decrease. The second outcome is that fibrillation results in stasis of some of the blood that's held in the atria. This small volume of blood is going to be prone to the internal clotting mechanism, or hemostasis, and hence small thrombi can form in the atria. These do have the possibility of migrating into the ventricles and being pumped out into either the pulmonary or the systemic circulation, and it is this that makes the likelihood of thromboembolic events such as a pulmonary embolus or a stroke much more likely. So let's quickly recap atrial fibrillation. The main characteristics of atrial fibrillation are an irregular rhythm, the absence of P waves, and the presence of F waves on the baseline instead. The absence of the P wave means there will be no PR interval to measure. You can see on the slide here there's some specific terminology that relates to atrial fibrillation. The term slow is used to indicate ventricular rates of less than 60 beats per minute, while the term controlled to identify normal heart rates, that is ventricular rates that fall between 60 and 100 beats a minute. And finally, we talk about rapid or uncontrolled atrial fibrillation when the ventricular rate is greater than 100 beats per minute. Just a word of warning is to ensure that when you're dealing with atrial fibrillation cases, to take mechanical pulse rates over longer periods of time, say 30 seconds as opposed to the normal 10 or 15 seconds. And this is going to give you a far better indication of the actual minute rate. Heart rate indicators on monitoring and pulse oximetry equipment often average the ventricular rate over shorter periods of time, say 10 or 15 seconds. And so what you might see is very significant variance in what they assume the minute rate to be. The rest of the information covering these characteristics are covered in the previous slides, and I've gone more into the causes and to the significance in those. The last point I want to make about atrial fibrillation is to be aware that you should be considering differential diagnosis for atrial fibrillation, particularly if you're dealing with tachycardias that might involve pharmacological treatment. The first point to consider is whether or not it's an irregular narrow complex tachycardia. And if this is the case, there are three options that you should always consider in terms of a differential. The percentage shot is atrial fibrillation, so that should always be on the radar for an irregular rhythm. The other two you should be thinking about and looking for evidence of is that it is a multifocal atrial tachycardia, or we're dealing with atrial flutter with a variable conduction rate. The information you need around the multifocal atrial tachycardia is covered in a session that we had before this one on atrial dysrhythmias, and we're going to go on and look at atrial flutter now.